Okay, thanks very much and good morning everyone. I'm really amazed by how many audience is available early in the morning with the trouble and the traffic in Riyadh. I thank the organizing committee for inviting me, and I thank them very much for using or choosing this very ignored topic, respiratory effort monitoring. And the first question I'd like to ask, why do we need respiratory effort monitoring? The reason is simply we need it to protect both the lung and the diaphragm. Now, we are all aware that control mode ventilation could be hazardous to our lungs. It can cause what we call VI-LI, ventilator-induced lung injury. And the reason we know that is that there is a parameter that can help us predict such injury, which is the airway pressures, particularly the plateau pressure. And the reason why it is easy to predict, because the plateau pressure in passively ventilated patient equals roughly the transpulmonary pressure, and the transpulmonary pressure is the pressure that determines the lung injury in vented patients. If we go to assisted ventilation, do we really have lung and diaphragmatic injury? We don't know, because it is invisible to us. There are no parameters that we can see in the ventilator that can tell us that the patient is at risk of lung injury or diaphragmatic injury or not. And the reason for that is simple. The transpulmonary pressure that we used to rely on here does not equal only the airway pressure. You have to subtract the pleural pressure from it, and as you know, it's very hard to measure the pleural pressure. So in fact, there is assisted ventilation-induced lung injury. It's called patient self-inflicted lung injury, and could be as bad or even worse than the ventilator-induced lung injury in control mode of ventilation. In addition, there is also diaphragmatic injury that's usually referred to as diaphragmatic myotrauma. So, in order for us to avoid such injury in assisted ventilation, we have to balance the level of assistance that's delivered by the ventilator and the respiratory effort that the patient is exerting during assisted ventilation. Now, if you have excessive level of assistance, you may damage the lung by causing lung injury. And you may cause diaphragmatic atrophy because of disuse. On the other hand, if the respiratory effort is too excessive because of increased respiratory drive or because of under assistance, then you are likely to damage here the diaphragm, causing diaphragmatic myotrauma. And is that important? The answer is yes. If you have such injuries, you can delay weaning, you can cause more trauma to the lung, prolong the intubation period or ventilation period, and you may even can increase complications and mortality. So it's very important. Before I go further to the mechanism of the assisted ventilation-induced injuries, I'd like just to clarify a very important concept, which is Pendeloft. Now, after a tidal breath is delivered with all of its consequences to the lung, there's something else that happens inside the lung. There's movement of air from certain areas of the lung to other areas, depending on the mechanics of that particular area. And this by itself can cause injury. It happens also during exhalation and after exhalation with assisted ventilation. So it may be as injurious to the lung as the VI-LI. So I tried to create this slide. I thought it would be kind of simplified. It ended up to be a very complicated slide. The mechanisms of lung and diaphragmatic injury in assisted ventilation. So number one, lung injury can happen because of increased global stress to the lung when the tidal volume is delivered. And this will cause volumetrauma. Because of Pendeloft, you will have increased regional stress to certain areas of the lung, and this will cause regional injury of the lung. Now, your patient is creating a tremendous amount of negative intrathoracic pressure because of assisted ventilation. And this will increase the transvascular pressure, attracting more fluid to the lung, causing increased lung water, which is bad. Asynchrony per se can result in volume and barotrauma to your lung. And we usually use low PEEP during assisted ventilation for weaning, and this may cause atelectasis and atelectotrauma. All of these together can cause significant amount of lung injury. Now, what about diaphragmatic injury? The first and the most important is unloading of the diaphragm. If you use excessive assistance, this will make your diaphragm work less, so there will be disuse atrophy. On the other hand, if you use little bit of assistance during assisted ventilation, you will cause something called concentric loading. That is to say, your diaphragm is working too hard to create that amount of tidal volume. This will result in inflammation and microscopic changes in the diaphragm, as if I'll just make it similar to the rhabdomyolysis that happens to patients who undergo stressful exercise. An eccentric form of loading can happen with this synchrony. This synchrony happens a lot during assisted ventilation. And what I mean by eccentric loading, when the diaphragm contracts where it should relax, or vice versa. So there will be double triggering, reverse triggering, and this could be even more injurious to the diaphragm than the concentric loading. High PEEP will affect the performance of the diaphragm by causing some mechanical disadvantage, and this will make the diaphragm work harder, causing more injury. Denutrition, which happens commonly in our patients with critical illness, and this will cause atrophy. And also excessive sedation can result in atrophy as well. Now, the right-sided and the left-sided, elements can overlap and can cause both injury to the lung and diaphragm. Don't forget that the patient comes up with sepsis, which is the most common. And sepsis, has the cytokine storm, has the oxidative stress that has its impact. The initial insult, which is usually infection, the comorbidities of the patient, all of these will add together with all of these factors to cause lung and diaphragmatic injury. Now, there are several studies that prove what I've mentioned. Because of time constraints, I will just skip them. This study is really nice and tells you how fast the diaphragm atrophies with sepsis and mechanical ventilation compared to the psoas muscle. For example, in sepsis, you see the atrophy that happens to the diaphragm as compared to the psoas muscle is quite more significant. This is the Canadian group did a small, very nice study that shows that the diaphragm takes longer than expected to show some activity. Here, 24 hours, it can reach up to 5 days to start working after sepsis and mechanical ventilation. And they noticed also that two important factors play a role here. If the patient was over-sedated or was mainly on passive ventilation during mechanical ventilation, the recovery will be delayed even further. And this is independent to the reason for intubation or the disease severity. So there are two independent factors. So this shows that monitoring respiratory effort is extremely important. So how can we do so? In fact, there are 8 objective parameters. The first one is the transpulmonary pressure. This is the abbreviation. Respiratory muscle pressure. Transdiaphragmatic pressure, which is mainly used for research. The inspiratory occlusion pressure, which is similar to the plateau pressure we use with controlled ventilation. The expiratory occlusion pressure. The respiratory occlusion pressure, which is the P0.1, which is very, very important, and it's the occlusion pressure at 100 milliseconds of inspiration and assisted ventilation. Then using diaphragmatic electricity, so diaphragmatic electrical activity, and I'm an ultrasound guy, so I have to talk about ultrasound too. So the use of diaphragmatic thickness gradient with ultrasound is also useful. So I had to delete several slides, and I said that to Mike, as if I'm cutting pieces of my heart when I deleted them, because otherwise I wouldn't finish the presentation. So I'll focus on these three parameters. So starting with transpulmonary pressure, do you know what is this? This is the esophageal manometer. It is a symbol. It is extremely underutilized in the clinical practice, although it's the gold standard for respiratory effort monitoring. The esophageal pressure probe. And you can just put it at the mid-esophagus. It has a balloon on top of it. And then you can monitor the esophageal pressure on timely manner. So what is the importance of the esophageal pressure? In order for you to measure the transpulmonary pressure, you should know the pleural pressure, because the transpulmonary pressure is the airway pressure minus the pleural pressure. In order to do so, you have to put a probe inside the patient's pleura, which is totally unpractical. So that's why we use the esophageal pressure as a surrogate for the pleural pressure. So the transpulmonary pressure is the airway pressure minus the esophageal pressure. So why do we need to measure the esophageal or to calculate the transpulmonary pressure anyway? Because it is the pressure that is directly proportional to the lung injury that happens during mechanical ventilation, whether assisted or controlled. So remember that the airway pressure is positive, and remember that the esophageal pressure during assisted ventilation is negative. So if you subtract the two, in fact, you are adding the two numbers. So let me give you an example. This is a very nice study that was published by this guy who I cannot pronounce his name. And it shows in patients with severe lung injury, this is an animal study. In animals with severe lung injury, when you apply passive ventilation, the airway pressure is positive. And the pleural pressure is positive because the patient is not participating. So the transpulmonary pressure will be the subtraction of the two. So it will be less than the airway pressure that is shown in the monitor. On the other hand, these patients have severe lung injury, so they have high respiratory drive, so they can suck air like hell. If you apply assisted ventilation to these patients, again, the airway pressure is the same as in the passive ventilation. But the difference here is that the esophageal pressure will be significantly increased in the negative side because of the increased effort that the patient is exerting. And here, instead of you subtracting the two pressures, because this is negative, and negative will be positive, so you will add the two pressures, you will end up with an extremely elevated transpulmonary pressure. If you remember, I said transpulmonary pressure correlates with lung injury. So these patients will definitely develop severe lung injury. Although they are on passive ventilation, they are on assisted ventilation. See, these are the lungs of the animals who were on passive ventilation, on assisted ventilation. It's extremely damaged compared to those on passive ventilation. So what is the transpulmonary pressure that is safe to our patients? No one knows, but a number of around 20 cm water is considered to be safe in patients with injured lung. So if your transpulmonary pressure is 30 or 35, then your patient is in trouble. You have to adjust the ventilator or the patient. I wanted to say something also here, which is the fact that not only the peak transpulmonary pressure is important, the transpulmonary pressure is a dynamic pressure. and bendel loft play a major role. Although we use the peak transpulmonary pressure as a measure, but there are many factors that play in this particular situation. Moving to the next and very important factor, which is the airway occlusion pressure, which is P 0.1. And in fact, what you do is that at end expiration, when the flow is 0, you apply occlusion, and you measure the pressure in the first 100 milliseconds of that occlusion. It has been shown that this pressure is reproducible and it's independent of lung mechanics and diaphragmatic function. And if it is high, for example, this patient has low pressure support and its P 0.1 is quite high, 3.5. It is negative, of course. While this patient is on high support and the P 0.1 is only 0.7. So this patient has high effort because of low support, and this patient has low effort because of high support. Neither of these situations is good, because this patient will have lung injury, this patient will have diaphragmatic injury. So this study identified the cutoff limits, which is 1, below 1, it's considered to be low effort with high sensitivity and specificity. And if it is more than 3.5 or 4, then this indicates high effort with decent sensitivity and specificity. Now I'll play this very nice video, and I took it from the net. Now this is a patient who's on assisted ventilation, pressure support of 10, PEEP of 10, tidal volume as you see is around 600, and the RR is 25. Using special maneuvers, you can hit start and measure the P 0.1, which was 3.6. You can measure it continuously or at certain intervals like 10 minutes. So now going to the same patient immediately, by decreasing the pressure, the amount of support you are giving to your patient from 10 to 4. This will result in decreased tidal volume, of course, because you decrease the amount of support, and will increase the RR. Now, the operator here is going to remeasure P 0.1. By the way, most
2 minutes.
عندي أنا 3 دقائق. So remeasuring P 0.1 showed that the number is extremely higher than it was before. So this indicates that the patient is having high effort. Now, I'll just skip the slide for the sake of time. Now, diaphragmatic thickness or thickness fraction is important. What you do is you examine the diaphragm, you measure end expiratory thickness and end inspiratory thickness, and normally with quiet breathing it should be 15 to 30% using this equation, and if it is less than 30 with maximal inspiratory effort, then it indicates diaphragmatic weakness. So these are the normal values. Because my colleagues asked me to speed up, I'm speeding up. Moving to the conclusion, and this is the take-home message, and I hope everybody grasps this. Remember, with assisted ventilation, you can still damage the patient's lung. This is number 1. Number 2, the diaphragm is similar to any other muscle in your body. If you don't use it, it will undergo disuse, atrophy. So if you under-assist the patient, so if you over-assist the patient, your diaphragm may undergo atrophy. If you under-assist your patient, the diaphragm will work harder, so it will have a rhabdomyolysis kind of thing. How to monitor that? These are the parameters that I've spoken about, particularly P 0.1, transpulmonary pressure, electrical activity of the diaphragm, and diaphragmatic thickness fraction. Again, you have to maintain a balance between level of assistance and the respiratory effort. If the level of assistance is excessive, you will damage the lung and you will cause diaphragmatic atrophy. So you can either adjust the sedation, the amount of support you are giving to your patient, the PEEP, the FiO2, the inspiratory flow, change the mode of ventilation. On the other hand, if the respiratory effort is excessive, then you can cause tremendous diaphragmatic injury, so you can help your patient by adjusting these parameters again in the other direction, or using a different mode of supported ventilation. I hope this talk is useful, and I hope to open the window for my colleagues to utilize such parameters in the ICU. And by this I'll end, and thank you very, very much.